Hello everyone, this lesson is on hand, foot and the mouth disease or HFMD. Hand, foot, mouth disease is a clinical syndrome characterized by an oral lantern and a macular or maculopapular or vesicular rash of the hands and the feet caused by enterovirus of Picornaviridae family. Most commonly, HFMD is caused by Coxsackie virus A16 and enterovirus 71. Herbangina is a benign clinical syndrome characterized by fever and a painful papulovesicular ulcerative oral lantern. The main difference between Herbangina and HFMD is Herbangina only causes lesion on the oral cavity, whereas HFMD involves rash of hands and the feet. Humans are the only carrier for those viruses that causes hand, foot, mouth disease. The disease is spread by fecal oral, and respiratory droplet contact. The patient is most infectious during the first week of illness. However, an active virus might present in the stool for up to 4 to 8 weeks or 1 to 2 months. Incubation is around 3 to 7 days. And oral ingestion of virus that is shed from the GIT or upper respiratory secretion of infected individuals or contact with vesicular fluid causes this disease. Once ingested, enterovirus replicate in the submucosal lymphoid tissue of the intestine, pharynx, and then to the regional lymph nodes. Replication at the sites leads to a minor viremia or a primary viremia, and this causes infection of reticuloendothelial system and the multiple organs, including CNS, heart, liver, and the skin. Then the clinical manifestation appears. Further replication at the disseminated sites and the major viremia and the type-specific antibody develops. This is followed by days of infected cells with inflammation and necrosis. When we see the clinical features, hand, foot, mouth disease is a clinical diagnosis based on the presentation of a low-grade fever, sore throat, malaise with a maculopapular or papulovesicular rash on the hands and the soles of the feet and by painful oral ulcerations. The diagnosis of hand, foot, mouth disease is usually made clinically. The virus can be detected in the stool for about 6 weeks after infection. However, shedding from oropharynx is usually less than 4 weeks. When etiologic confirmation is necessary, throat, stool, and the vesicular fluid samples should be obtained for PCR. Light microscopy of biopsies or scraping of vesicles will differentiate HFMD from varicella zoster virus and herpes simplex virus skin lesion. Both varicella and herpes simplex virus have multinucleated and giant cells in smears taken from the moist skin exposed when a vesicle is removed. This is done by zinc smear. Giant cells are not present in lesions of HFMD. When we see the management of hand, foot, mouth disease, management is supportive, directed toward the relief of pain, lowering of fever, and the adequate oral hydration because of the self-limiting nature of hand, foot, mouth disease. Admission and intravenous fluid might be required if the child is unable to take orally, or if the child is dehydrated or clinically ill, or in the case of CNS or cardiac complications. Pain and the fever can be managed with non-steroidal anti-inflammatory drugs and acetaminophen, but preferably avoided in children with dehydration. Regarding prognosis of HFMD is excellent, and most of the cases recover within few weeks without residual sequelae, and acute illness lasts for 10 to 14 days. Some may develop serious complications such as persistent stomatitis, CNS complications, interstitial pneumonia, pulmonary edema, myocarditis, and pericarditis. Regarding prevention of HFMD, proper hygiene, hand washing after contact with patient and after diaper handling, disinfection of surface and the toys, avoid close contact and the sharing of utensils and the cups with infected person, and the proper disposal of wastes are the main mechanism to prevent hand, foot, and the mouth disease. This is all about HFMD. Thank you for watching.